If you've had more than 2 urinary tract infections in the last year, this video is going to change how you think about every single one of them. I had a patient last month who told me something I hear almost every week. Doctor, I take the antibiotic, it goes away, and 2 months later it's back. What is wrong with me? Nothing is wrong with you, but there is something almost nobody explains about why the infection keeps coming back and what the antibiotic you've been taking may actually be doing to your long-term protection. Most people assume recurring UTIs mean their body is simply failing, that they're unlucky, that they just have to live with it. Actually, none of those are true. So I need you to pay close attention because what I'm about to share with you today could completely change the way you understand your body. These are things that most people are never told, and once you understand what's really happening, everything starts to make sense. More importantly, you'll discover what you can do to finally start solving the problem. My name is Dr. Kaiser. I'm a cardiologist, and I specialize in recognizing the warning signals your body is constantly sending you. And this is the health signal. Stay with me until the end, because by the time we're finished, you'll understand exactly why this infection keeps coming back. And, most importantly, what we do differently to finally break this cycle, especially in both men and women over the age of 65. Let me show you something fascinating. Large observational studies suggest that roughly 10 to 15% of all women over 60 experience recurring UTIs. And in postmenopausal women specifically, the recurrence rate after a first infection is around 55%, compared to just 19 to 36% in younger women. That's not bad luck. That's biology. And it has a specific explanation most doctors never take the time to give. Take a breath with me for a second, because what I'm about to explain changes how you'll think about every UTI you've ever had. Most people assume the infection comes back because the antibiotic didn't fully work. Actually, that's often not the reason at all. The antibiotic usually works perfectly. The infection clears. But the reason it happened in the first place is still there, untouched, waiting. And a few weeks later, it opens the door again. So the question isn't, why doesn't the antibiotic work? The question is, why does the door keep opening? Have you ever noticed that over time, you stop planning trips without mapping out bathrooms first? That you hesitate before a long car ride? That something as simple as dinner with friends becomes a quiet negotiation with your own body? That's what recurring UTIs actually take from you. Not just comfort, independence. Stay with me here, because this next part is the reason I wanted to make this video. Think of the lining of the urinary tract like a well-maintained garden wall. When that wall is strong, bacteria that approach it have a very hard time getting through. In women, estrogen is one of the key builders that maintains that wall. It supports the protective bacteria that guard the urinary tract and keeps the environment hostile to infection. After menopause, estrogen levels fall. The wall thins. The protective bacteria diminish. The door becomes easier to push open. This surprised me when I first studied the research, because we don't usually think of estrogen as a urinary protector. But the American Urological Association's 2025 guideline is explicit. Vaginal estrogen therapy is now recommended for postmenopausal women with recurrent UTIs when there's no contraindication. In men, the picture is different but equally real. An enlarged prostate after 60 can make it harder for the bladder to drain completely. Urine that pools instead of draining creates exactly the warm, stagnant environment bacteria need to multiply. Two different mechanisms, one result in common. Now here's the part that surprises almost every patient I see in my office. There is a difference between a UTI and a colonized bladder. And most people have never been told this distinction exists. Most people assume that bacteria in the urine always means infection, always means you need an antibiotic. Actually, that is not true. Research shows that up to 50% of women over 65 have bacteria in their urine at any given time. Without any infection at all, No pain, no urgency, no burning. They feel completely well. This is called asymptomatic bacteriuria. And the critical point, treating it with antibiotics does not reduce your risk of future infections. Multiple clinical trials, reviewed by the Infectious Disease Society of America, have confirmed this for decades. What happens is that repeated treatment with antibiotics can select for more resistant bacteria. So, the next time you develop a real infection, the antibiotic that always worked before may no longer work. But that does not mean you should stop taking any medication your doctor has prescribed. Before stopping or changing any medication, you need to speak directly with your doctor. Because every case is different, and every patient deserves an individual evaluation. Please don't forget that. Have you ever noticed that each UTI seems to need a stronger antibiotic than the last? This is exactly why. I want you to really hear what that means in practice. I've had patients who arrived at the emergency room with a urinary infection, and we had no oral antibiotic that could treat them at home. Every option had been burned through by years of prescriptions for bacteria that wasn't causing any infection. They needed intravenous treatment in the hospital for an infection that years earlier would have been a simple 3-day course at home. That is what the cycle of overtreating a colonized bladder can eventually cost you. Stay with me, because once you understand what comes next, everything will start to make sense. Think of your antibiotic protection like a set of light bulbs. Each antibiotic is a different bulb. You have several, and they work. But if you leave the lights on all the time, even when you don't need them, the bulbs burn out faster. And when you finally need them in the dark, you flip the switch and nothing happens. The antibiotic isn't the problem when you truly need it. The problem is using it when the bacteria wasn't causing harm in the first place. There are actually 3 things happening when this cycle continues. The first affects your protection today. The second affects your options for the future. The third is the one I think about most, and we'll come back to it shortly. So how do you tell the difference between a real UTI that needs treatment and a colonized bladder that doesn't? The answer is symptoms, specific ones, located in the right place. A real UTI typically comes with pain or burning when you urinate, a feeling of urgency that hits suddenly and is much stronger than usual, needing to go very frequently, often with almost nothing coming out, pain or pressure in the lower belly, or back pain just below the ribs, where the kidneys sit, sometimes blood visible in the urine. What does not reliably indicate a UTI on its own? Urine that smells different. Urine that looks cloudy or darker. Feeling generally tired or not quite yourself. Confusion on its own, without the bladder symptoms we just described. I want you to hear something important. Those last symptoms deserve attention, but they deserve their own investigation, not an automatic assumption that the bladder is to blame. Be honest. The next time you or someone you love gets a urine test, was there a conversation about these specific symptoms? Or did the positive result lead straight to a prescription? Tell me in the comments. Now here is the third point I mentioned earlier, and this is the one that concerns me the most. So I want you to stay with me and pay very close attention to the details. When a person over 60 comes in feeling vaguely unwell, tired, a little confused, not finishing their meals, it is incredibly common for the response to be automatic. Check the urine, find bacteria, prescribe antibiotics. But if a 25-year-old woman came in with those exact same vague symptoms, her bladder would almost never be the first thing a doctor would check. Instead, they would think about stress, mood, her thyroid, sleep, medication side effects, almost anything, before they thought about her bladder. Something changes when people get older. The bladder becomes the first suspect, always. And real causes, depression, constipation, medication changes, dehydration, go undiagnosed, while the antibiotic treats bacteria that was never causing the problem. The price of that mistake isn't just medical, It's the weeks of assuming something was wrong with your bladder when the real answer was somewhere else entirely. That delay matters. Don't worry about memorizing all of this right now. By the end of this video, I'll give you the exact questions to bring to your next appointment. For now, let me introduce two more patients whose stories complete this picture. Barbara, 68, a retired school teacher, loved walking her dog every evening after dinner, until UTI after UTI started making her afraid to leave the house without knowing where every bathroom was. She had been on antibiotics 6 times in 18 months. Each time the infection cleared, each time it came back within weeks, sometimes stronger. We stopped the antibiotic cycle. We addressed the root cause instead. The fall in estrogen after menopause had thinned the protective lining of her urinary tract. We introduced low-dose vaginal estrogen, one of the few interventions with strong clinical evidence for exactly this pattern. We worked on consistent hydration, regular bladder emptying, and bowel regularity, because constipation actually increases UTI risk by pressing on the bladder and reducing its ability to drain properly. Most people have never heard this connection. 6 months later, Barbara had 1 infection, not 6. "Doctor, I walked my dog 3 evenings last week," she told me. "The whole neighborhood loop. I didn't think about a bathroom once." Can you picture that? Walking your neighborhood again, just walking, without that quiet anxiety that had become part of every step. Now, let me tell you about George, 72 years old, a retired engineer, an extremely methodical, detail-oriented man. He had been struggling with recurrent urinary tract infections ever since he turned 69, and he believed this was something unusual for men, a problem that only affected women. He was right that UTIs are more common in women, but they are not rare in men over 60. What we found changed his entire picture. George had an enlarged prostate, not cancer, simply a prostate that had grown with age, as they often do. It was squeezing the urethra just enough that he could never fully empty his bladder. The urine pooling inside was giving bacteria exactly what they needed to multiply. Not his hygiene, not his diet, not anything he was doing wrong. A structural change that had gone unconnected to his infections for 3 years. We addressed the prostate. His UTI rate dropped dramatically. George told me the thing that stayed with him most was not the diagnosis itself. It was that nobody had connected the two things, even though he'd mentioned both to his doctor in the same appointment more than once. Before I show you exactly what to do, there's one mistake almost everyone with recurring UTIs makes, and it may be the single biggest reason the cycle never breaks. The biggest mistake almost everyone makes with recurring UTIs is this: treating the urine instead of treating the person. A positive urine culture is a lab result. It tells you bacteria is present. It does not tell you whether that bacteria is causing your symptoms, or whether it was already living there quietly before your symptoms started. When every appointment ends with, "Your urine was positive, here's an antibiotic," the conversation that never happens is, "Why is your bladder not protecting itself? What changed? What are we missing?" The first step to solving this is identifying it and understanding the cause. That conversation changes everything. Your doctor is not hiding something from you. A standard 15-minute appointment simply does not have room for this conversation unless you specifically ask for it. And most people never ask because they never knew the question existed. That is exactly why I made this video, and it's exactly why what comes next matters. Here's what actually has clinical evidence behind it for recurring UTIs after 60. For postmenopausal women, low-dose vaginal estrogen, not the same as systemic hormone therapy, a small amount applied locally. It restores some of the protective lining that estrogen loss took away. The 2025 AUA guideline lists this as a moderate recommendation with grade B evidence. That is a meaningful clinical signal. Hydration. Flushing the bladder regularly removes bacteria before they have time to establish themselves. Not drinking to excess, just consistently through the day. Now, here's something that surprises almost everyone. Your bladder and your bowels are much more connected than most people realize. When your bowel stays full, it can press directly against the bladder, making it impossible to empty completely. And that small amount of urine left behind can become the perfect place for bacteria to grow. Timed voiding. Emptying the bladder regularly, even when urgency isn't yet strong, reduces the pooling that gives bacteria an opportunity. For men with an enlarged prostate, addressing the prostate issue itself, not just treating the infection that results from it. And one more option fewer people know about: methenamine. Not an antibiotic, but a medication that acidifies the urine, making it hostile to bacterial growth. A clinical trial showed it reduces recurrence at a rate roughly equivalent to low-dose preventive antibiotics, without the resistance risk. Requires a prescription and doctor supervision, particularly if kidney function is reduced. Two things widely recommended, but with weaker evidence than most people believe. Cranberry supplements. You've probably heard this one for decades. When the data is examined carefully, it does not show a strong, consistent benefit. It's unlikely to cause harm, but I wouldn't rely on it as your main prevention strategy. D-mannose. Some emerging data, not yet strong enough for firm clinical recommendations. Worth discussing with your doctor if you're interested. Now, the symptoms that mean you need care today, not in a few days. Fever above 99 degrees, especially combined with chills. Back pain just below the ribs on one or both sides. Nausea or vomiting alongside urinary symptoms. A feeling that you are genuinely systemically unwell, not just uncomfortable. These warning signs may mean the infection has reached your kidneys or even your bloodstream. At that point, this is a medical emergency. It is not something you should wait and hope gets better on its own. Do not ignore these important warning signs your body is sending you. Seek medical care as soon as possible. The sooner you're evaluated by a doctor, the better your chances of preventing serious complications. For typical lower urinary symptoms without these red flags, a 48 to 72-hour culture period before starting antibiotics is often reasonable, if your doctor agrees. Let me show you something that connects to everything we've covered today. Your urine is one of the easiest windows into what's happening in your body. But most of what people look at doesn't mean what they think it means. Healthy urine is pale yellow. That's the goal. Dark yellow or amber, that usually means you're not drinking enough fluids. Try to stay hydrated consistently throughout the day. Proper hydration is essential for many parts of your body, including helping your bladder function properly and lowering the risk of urinary tract infections. Deserves a call to your doctor. It can sometimes indicate the liver isn't processing waste properly. Pink or red tinged could be blood from a kidney stone, bladder irritation, or something more serious. Always report it. Foamy or bubbly urine that doesn't clear quickly can sometimes signal protein leaking through the kidneys. A simple urine test can check this. Strong or unusual odor by itself, almost never a reliable sign of infection. Asparagus, vitamins, certain medications all change urine odor without any problem present. Cloudy urine on its own, also not a reliable infection sign. Often just dehydration or concentration. Here is what actually matters: the combination of what you see with what you feel. Urine appearance alone, without symptoms, rarely tells the whole story, and it should never be the sole reason for an antibiotic. A few questions I hear constantly about this. My urine culture was positive, but I have no symptoms. Should I take the antibiotic? In the absence of true UTI symptoms, most clinical guidelines recommend against treatment. Ask your doctor specifically whether your symptoms warrant it or whether the positive culture may reflect colonization. Can I take cranberry supplements to prevent UTIs? The evidence is weaker than the marketing suggests. It's unlikely to cause harm, but I wouldn't rely on it as your main strategy. Focus on hydration and the interventions with stronger evidence. My doctor always prescribes antibiotics when I call about a UTI. Should I push back? You can ask, specifically, do my symptoms match a true infection? Can we culture first and confirm before I start the antibiotic? Most doctors will respect that question. Is vaginal estrogen safe after a history of breast cancer? That requires a direct conversation with your oncologist. Some situations allow it, others don't. Never change or start a hormone-related treatment without that specific conversation. I'm a man. Can I really get recurring UTIs? Yes, especially after 60. Prostate size, bladder emptying, kidney stones, all increase the risk. The same principle applies. Symptoms first, culture to confirm, and address the underlying structural cause. Here are the exact questions to bring to your next appointment. Write these down or take a screenshot right now. 1. Do my current symptoms specifically point to a bladder infection, or could they have another cause? 2. Can we send a urine culture first and confirm the bacteria before I start an antibiotic? 3. Could this be a colonized bladder, meaning bacteria that was already there before my symptoms started? 4. For women, could vaginal estrogen help reduce my recurrences, and am I a good candidate for it? 5. For men, could my prostate be affecting how well my bladder empties, and is that contributing to the infections? 6. What is the shortest course of antibiotics that would be appropriate if I truly need one? 7. Is there a structural reason for these recurring infections, like a kidney stone, bladder emptying issue, or prostate size? These 7 questions change the conversation from "here is your antibiotic" to "here is the reason this keeps happening." That is a completely different conversation, and it is the one that breaks the cycle. Quick checklist before we wrap up. If you have recurring UTIs, ask your doctor specifically about the underlying cause, not just the next antibiotic. A positive urine culture without clear UTI symptoms may reflect a colonized bladder, not a true infection. For postmenopausal women, ask about vaginal estrogen. It is now a guideline-backed option with real clinical evidence. For men over 60, ask whether prostate size or incomplete bladder emptying may be contributing. Stay consistently hydrated through the day, and keep your bowels regular. Bring the 7 questions from this video to your next appointment. Barbara walks her dog every evening now. The whole neighborhood loop. George hasn't needed an antibiotic in over a year. I want you to live longer. But more than that, I want you to live better, without that quiet anxiety before every outing, doing the things you've always done on your own terms. No matter how long this cycle has been going, today you finally have the conversation that was always missing. Every signal has a story. The sooner you understand that story, the more options you usually have. Your body is always communicating with you. You just have to know how to listen. How many UTIs have you had in the last year? Tell me in the comments. I read every one of them myself. If this helped you, hit like and subscribe to the Health Signal. If you know someone who's been treated for recurring infections with the same antibiotic again and again without anyone ever asking why, please share this video with them. I'm Dr. Kaiser. There's another video on your screen right now where I explain the warning signals your body sends before bigger problems begin. It connects perfectly with everything we talked about today. Click on it now. Thank you so much for watching. Take care, and I'll see you in the next video.